Usually when we talk about a medical diagnosis, there's this expectation of precision, like engineering.
Right, yeah. You want it to be black and white.
Exactly. I mean, you break your arm, the X-ray shows that jagged white line, and the doctor just points and says, there it is. It's broken or not broken. It's super clean and visible.
And we rely heavily on that, right? That visual confirmation provides this, well, this sense of control over the pathology.
But then you step into the world of pediatric neurology and neuromuscular emergencies, and suddenly that X-ray machine is just entirely useless.
Yeah, completely useless. You're looking at a diagnostic landscape that is, frankly, entirely murky.
Right. And when a child's nervous system misfires, doctors basically had to act as, like, top-tier detectives in the dark. So for you listening right now, today we are decoding that detective work.
It's fascinating stuff, really.
It really is. We are doing a deep dive into the management, highly specific drug protocols, and the critical emergency steps for 4 really devastating conditions.
Specifically, we're looking at myasthenia gravis, muscular dystrophies, focusing on Duchenne, muscular dystrophy, spinal muscular atrophy, and finally, pediatric coma.
Yeah, so whether you're a medical student prepping for your rotations or a curious parent or just someone fascinated by the incredible machinery of the human body, you're going to walk away from this deep dive with a really profound understanding of how we measure, manage, and fight for the nervous system when it just, fails.
And the progression we're going to trace today is really a spectrum of mechanical and electrical failure.
Like going from bad to worse, basically.
Exactly. We start by examining what happens when the connection between the nerve and the muscle simply drops out. Then we observe the consequences of the muscle fiber structurally collapsing under its own weight.
Wow, okay.
Yeah. And we move from there to the decay of the spinal nerve itself. And finally, we'll explore the macroscopic system override, which is a total failure of consciousness resulting in a coma.
And in every single one of these scenarios, time and the relentless pursuit of objective measurement are the ultimate lifesavers, right?
Absolutely. Time is brain, as they say, or in some cases, time is muscle.
Right. So before we look at muscles that structurally fail or decay, I think we have to understand what happens when the signal to move simply gets intercepted.
Which brings us to myasthenia gravis, or MG.
Yeah, MG. And to really grasp this, we need to zoom way, way in on the neuromuscular junction, right?
We do. The neuromuscular junction, or the NMJ, is this, right, a neurotransmitter called acetylcholine. We usually just refer to it as ASHI.
So the electrical signal gets converted into a chemical spray.
Exactly. That chemical spray diffuses across the microscopic synaptic cleft. And that brings us to step 2.
Which is the actual connection.
Right. The acetylcholine molecules physically bind to highly specific acetylcholine receptors that are embedded in the folded surface of the muscle membrane.
And that binding is like turning the key in the ignition.
Perfectly said. It opens ion channels, allowing sodium to rush into the muscle cell, which generates the electrical spark that causes the actual physical contraction of the muscle fiber.
But obviously the muscle can't just stay contracted forever, or you'd be like rigid as a board. You have to reset the system for the next movement.
Yeah, you'd be totally stuck. So step 3 is the cleanup phase. There's an enzyme called acetylcholinesterase, which is heavily concentrated in that synaptic gap.
Acetylcholinesterase, that's a mouthful.
It is, yeah. But its sole job is to rapidly hydrolyze or break apart the acetylcholine molecules mere milliseconds after they bind to the receptors.
So it destroys the signal almost immediately.
Exactly. By destroying the neurotransmitter, the signal is terminated, the ion channels close, and the muscle relaxes.
Okay, so I'm picturing this like a highly coordinated, busy parking lot.
I like this. Walk me through it.
So step 1, a massive fleet of cars, which is the acetylcholine, arrives at the lot. Step 2, the cars look for open parking spots, which are the receptors on the muscle. When they park, the muscle flexes.
Right, they take up the spaces.
And then step 3, the tow trucks, which are the acetylcholinesterase enzymes, come in immediately, tow the cars away, and clear the spot so the muscle can relax and get ready for the next waves of cars.
That analogy actually perfectly illustrates the normal physiology, but in myasthenia gravis, the catastrophic failure occurs squarely in step 2.
The parking phase.
Right. MG is an autoimmune disorder. The body's immune system, which is, supposed to hunt down foreign invaders like viruses, gets confused and starts producing anti-AP receptor antibodies.
Wait, I want to push back on this to make sure I really get the mechanics. If this is an autoimmune attack, what is actually taking the damage?
That's the key question.
Are the antibodies destroying the muscle tissue, or are they, like, eating the nerve ending?
They're actually doing neither, at least not in the sense of direct cellular destruction at first. The mechanism is steric hindrance and accelerated degradation.
Steric hindrance, so they just get in the way.
Exactly. The antibodies physically bind to the AK receptors on the muscle membrane. They park in the parking spots, using your analogy.
Oh, wow. So they just block the cars from pulling in.
Yep. And furthermore, their binding causes the muscle cell to internalize and destroy its own receptors faster than it can replace them.
So not only are the spots blocked, but the parking lot is actively being paved over.
That's a great way to put it. So when the nerve releases the acetylcholine to tell the muscle to move, the neurotransmitter arrives at the muscle and finds that the vast majority of the receptors are physically blocked by the body's own antibodies, or they're simply gone.
The signal just gets intercepted, the brain says move, the nerve fires the chemical, but the muscle just can't get the memo because its inbox is jammed with these rogue antibodies.
And this mechanism directly explains the hallmark clinical symptoms of myasthenia gravis, which are profound skeletal muscle weakness and, most crucially, fatigability.
Fatigability, meaning they get weaker the more they try to move.
Precisely. As the child tries to sustain a movement, the nerve keeps firing, but the few available receptors are rapidly overwhelmed and depleted. The more the muscle tries to work, the weaker it becomes.
That's terrifying. So how does this actually manifest in children? Because the sources outline 3 distinct types of pediatric MG. Let's look at the newborns first.
Right, the neonatal types.
Yeah, there's transient neonatal MG and persistent neonatal MG. And transient neonatal MG is terrifying because the infant doesn't actually have a defective immune system, do they?
No, they don't. Transient neonatal MG is actually a consequence of the maternal environment. It occurs in infants born to mothers who are actively suffering from myasthenia gravis themselves.
Okay, so how does it get to the baby?
Well, during the 3rd trimester of pregnancy, maternal IgG antibodies naturally cross the placenta to give the baby passive immunity. It's normally a good thing.
Right, to protect them after birth.
Exactly. But in this case, the mother's rogue anti-ACE receptor antibodies also cross the placenta. So the baby's bloodstream becomes totally flooded with the mother's disease-causing proteins.
Wow. So the baby is essentially just borrowing the mother's autoimmune disease for the first few weeks of life.
That's exactly it. And because the baby is born with a systemic blockade of their neuromuscular junctions, the symptoms are immediate and severe.
What does that look like in a newborn?
You see general floppiness, a weak cry, very feeble respiratory efforts, and a profound inability to suck and swallow.
I mean, a newborn relies entirely on those basic mechanical functions just to survive the first hours of life.
Right,
If they can't suck, they can't eat.
right.
If their diaphragm is too weak, they can't pull oxygen into their lungs. That's a massive emergency.
It is. Without immediate aggressive medical intervention, transient neonatal MG is rapidly fatal. The infant simply suffocates or starves due to mechanical failure.
But the word transient is key here, right?
Extremely key. The critical physiological detail here is that the baby is not producing these antibodies. They only have the supply they inherited from the mother.
And antibodies don't last forever.
Exactly. They have a half-life. If you secure the baby's airway, assist their ventilation, and feed them through a tube, the mother's antibodies will naturally degrade over 2 to 4 weeks.
And what?
Once the antibodies are gone, the disease completely abates. The baby is perfectly healthy.
Wow. But that waiting game requires immense support. I know the treatment protocols for this specific transient type include methods to manually clear those antibodies faster, like an exchange blood transfusion.
Yes. An exchange blood transfusion, or EBT, involves slowly removing the infant's blood and replacing it with donor blood or plasma.
You're just flushing it out.
Quite literally.
Yeah.
You are physically washing the mother's circulating antibodies out of the baby's vascular system.
Is that the only way to filter it?
No, plasmapheresis operates on a similar principle, but instead of replacing the whole blood, you run the baby's blood through a machine that specifically filters out the plasma.
And the plasma is where the antibodies are hiding.
Right, it's the liquid portion of the blood where the antibodies reside. Then the machine returns the red blood cells to the baby. By aggressively filtering the plasma, you free up the neuromuscular junctions much faster.
Okay, so that's the transient type. But contrasting that with persistent neonatal MG, the presentation looks exactly the same, right? The floppiness, the respiratory distress.
Clinically, yes, it looks very similar initially, but the underlying engine of the disease is completely different.
Because in the persistent form, the mother doesn't have MG.
Right. The mother is healthy, the neonate's own immune system has misfired and is intrinsically manufacturing the antibodies.
Ah, so the baby's body is the factory.
Exactly. And because the baby is producing the blockade, the disease will not simply wash away after a month. It requires lifelong pharmacological management.
Man, that's tough. Then we have the third category, which affects older children, juvenile MG.
Yes.
The epidemiological data here shows a peak incidence around 10 years of age. And it's, a staggering 6 times more common in females than in males.
That's what the data shows, yes.
And a 10-year-old is going to present very differently than a floppy newborn.
Completely differently. The clinical presentation in juvenile MG often begins with the smallest, most constantly active muscles in the body, which are the extraocular muscles.
The eye muscles.
Right, the tiny muscles that control the movement of the eyes and eyelids. They are constantly firing to keep your eyes aligned and open, which makes them highly susceptible to the fatigability of MG.
So what are the first signs parents might notice?
The classic early signs are ptosis, which is a drooping of the upper eyelids, and diplopia, or double vision.
Double vision.
Yeah,
Right, because if the tiny muscles pulling the left eye fatigue slightly faster than the muscles pulling the right eye, the eyes lose their perfect synchronization.
exactly. And when that happens, the brain receives two misaligned images.
That has to be terrifying for a kid.
It is. And unfortunately, the weakness then typically spreads to broader facial muscles, the limbs, and crucially, the intercostal muscles between the ribs that expand the chest for breathing.
But the sources mention a definitive diagnostic clue for juvenile MG, like the one element that separates it from, say, a brain tumor or a muscular dystrophy.
And that clue is that the weakness uniquely and predictably improves with rest.
Right, because giving the muscle a break stops the constant demand for acetylcholine.
Yes, it allows the junction to clear out, gives the antibodies a chance to detach slightly, and lets the nerve terminal rebuild its reserves of neurotransmitter vesicles.
It's like letting the parking lot clear out for a minute.
That's a good way to look at it. And it's a hallmark feature that leads directly into how we objectively diagnose the condition.
Okay, so if a 10-year-old girl presents with drooping eyelids and double vision that worsens toward the evening, how do you prove it's MG?
We utilize the edrophonium test. Edrophonium is a very short-acting, intravenously administered anticholinesterase drug.
Okay, going back to our parking lot analogy, if the anticholinesterase enzyme is the fleet of tow trucks constantly removing the cars, an anticholinesterase drug paralyzes the tow truck.
Exactly right. By pushing edrophonium into the child's feet, you are chemically paralyzing the enzymes that normally clean up the synaptic gap.
So without the cleanup crew, every single molecule of acetylcholine released by the nerve just remains in the gap.
Yes, the neurotransmitter rapidly builds up to massively high pharmacological levels.
So even though the rogue antibodies are blocking a huge percentage of the parking spots, you're just flooding the lot with such an overwhelming volume of cars that they force their way into whatever microscopic fraction of spots are left available.
You overcome the competitive blockade through sheer chemical volume, and the clinical result is startling.
Like, how fast does it work?
Within 30 to 60 seconds of the injection, the child's drooping eyelids lift completely, their vision snaps back into single focus, their limb strength returns.
Wow. It's just a dramatic, seemingly miraculous reversal.
It really looks like a miracle. But because edrophonium has a very short half-life, the enzymes recover within about 5 minutes. The excess acetylcholine is cleared, and the profound weakness rapidly returns.
So it's just a test. But that brief, undeniable spike in strength is your definitive proof. It isolates the pathology exactly to the neuromuscular junction.
Exactly.
So once you have that proof, how do you actually keep the child alive?
Right.
We discussed filtering the blood for neonates, but what are the long-term pharmacological protocols for a child living with juvenile MG?
Well, the pharmacological management is highly regimented. But first, the protocol dictates that in any acute myasthenic crisis, where the child is experiencing sudden severe weakness, the absolute first priority is securing the airway.
Airway first.
Always.
Always. If the intercostal muscles and diaphragm are failing, you do not wait for medications to take effect. You immediately intubate and assist ventilation.
Makes sense?
Secondly, if the facial and pharyngeal muscles are weak, the child loses the ability to safely coordinate swallowing. So you must pass a nasogastric or NG tube to bypass the throat and deliver nutrition directly into the stomach.
Right, so you secure the mechanics of life before you attempt to fix the chemistry.
Yeah, exactly. Once the airway and nutrition are safe, we look at the frontline drugs. The primary medication is neostigmine.
Neostigmine. And how does that work compared to the edrophonium test?
It operates on the exact same principle, but it has a much longer duration of action. It's an oral anticholinesterase that maintains a steady, continuous blockade of the cleanup enzymes, keeping the acetylcholine levels artificially elevated throughout the day. How often do they have to take it?
It's typically administered every 4 to 6 hours.
But the dosing schedule mentioned in the sources has this really critical, life-saving caveat regarding when to give it the pill, right?
It does. If the child has dysphagia, which is difficulty swallowing, the timing of the neostigmine dose is paramount. You must administer the medication exactly 30 minutes before they attempt to eat a meal.
Why exactly 30 minutes?
Because swallowing is a dangerously complex reflex. It requires the perfect synchronization of dozens of small skeletal muscles in the tongue, pharynx, and esophagus to push food into the stomach while simultaneously sealing off the trachea.
And if those throat muscles fatigue midway through chewing and swallowing a piece of food, the protective seal over the airway just fails.
Exactly. The child will aspirate the food directly into their lungs, which causes severe chemical pneumonitis, choking, and often fatal bacterial pneumonia.
Oh, man. So by administering the neostigmine exactly 30 minutes prior to the meal, you account for the drug's gastrointestinal absorption time.
Yes. You ensure that the concentration of the drug, and therefore the strength of the child's swallowing muscles, is at its absolute physiological peak precisely when they take their first bite of food.
It's a tiny detail that prevents lethal complications. Are there any other drugs in that class?
Another drug frequently utilized is pyridostigmine, which has a slightly different absorption profile but works on the exact same enzyme blocking principle.
Okay, so that manages the symptom, the blocked transmission. But what about addressing the root cause? Like, how do we stop the immune system from manufacturing the blockade in the first place?
For long-term disease modification, we introduce immunosuppressants. Prednisolone, which is a potent corticosteroid, is heavily utilized to broadly suppress the immune system's overactivity.
So it just dials down the production of the rogue antibodies.
Right. And in severe acute exacerbations where the child is crashing, we can administer intravenous immunoglobulins, or IVI.
What is that?
This involves infusing massive amounts of pooled, healthy antibodies from thousands of blood donors. These healthy antibodies essentially bind to, neutralize, and accelerate the clearance of the patient's destructive autoantibodies.
Wow, just overwhelming the bad ones with good ones?
Yeah.
There's also a surgical intervention listed in the management protocols, right? The thymectomy.
Yes. The thymus gland is this small organ in the upper chest, right behind the sternum, that is mostly active during childhood.
And what does the thymus actually do?
It's basically the central training ground for the immune system, specifically for T cells. In many patients with myasthenia gravis, the thymus is hyperplastic, abnormally enlarged, or it contains clusters of immune cells that are inappropriately directing the attack on the neuromuscular junction.
So they just remove it.
Yes, the protocols show that surgical removal of the thymus gland has been definitively proven to significantly improve symptoms, reduce the need for medication, and often induce permanent long-term remission, particularly in juvenile MG.
That's amazing. Okay, so that covers the intercepted signal. In myasthenia gravis, the motor nerve is perfectly healthy. The muscle fiber itself is structurally sound. The problem is entirely a biochemical traffic jam in the synaptic gap.
Right, a reversible blockade.
But this brings us to a much darker physiological reality. What happens when the signal arrives perfectly, the receptors are wide open, but the structural integrity of the muscle itself, or the nerve cable delivering the signal, is fundamentally rotting away?
And this is where we encounter the devastating pediatric conditions of Duchenne muscular dystrophy, or DMD, and spinal muscular atrophy, or SMA.
Yeah, the transition from MG to DMD and SMA is a transition from a reversible blockade to just a relentless progressive degeneration. Let's start with Duchenne muscular dystrophy. We're looking at the most common and the most severe form of muscular dystrophy in children here.
We are. And to grasp the pathology of DMD, we have to look past the neuromuscular junction and peer directly into the microscopic architecture of the muscle fiber itself.
I mean, muscle fibers endure immense physical stress. Every time a child runs, jumps, or even just breathes, those cells are stretching and contracting with massive mechanical force.
Exactly. But in DMD, there is a severe progressive loss of these muscle fibers. They're literally tearing themselves apart.
Tearing themselves apart? Why?
The cellular destruction in DMD all points back to the genetic deficiency of a single massive structural protein called dystrophin.
Dystrophin.
Yes. Dystrophin serves as a critical mechanical anchor. It physically connects the internal cytoskeleton of the muscle cell, the contractile machinery, to the extracellular matrix, which is the tissue surrounding the cell.
Okay, so if we imagine a muscle fiber as a massive load-bearing concrete pillar, the dystrophin protein is the internal steel rebar running through the center of the concrete and anchoring it to the foundation.
That's a perfect analogy. It provides tensile strength, it absorbs the shock, and stops the concrete from cracking under the shearing stress of movement.
So without that dystrophin rebar, the lipid membrane of the muscle cell is just incredibly fragile.
Incredibly fragile. Every time the muscle contracts to generate force, the membrane physically tears open under its own mechanical stress. Microtears occur continuously.
And a torn cell membrane is essentially a breached hull. Things from the outside fluid are going to rush in that absolutely should not be inside the cell.
Specifically calcium. The fluid surrounding muscle cells is rich in calcium ions. When the membrane tears, massive amounts of calcium flood into the intracellular space.
But isn't calcium needed for muscle contraction?
It is. Calcium is vital for initiating normal contractions, but a sudden, uncontrolled flood of calcium acts as a cellular self-destruct sequence. The high intracellular calcium levels hyperactivate internal enzymes called calpains, which are a type of protease.
Protease, so those are like microscopic biological scissors, right?
Exactly. Their entire function is to cleave and digest proteins. So because of a missing structural anchor, calcium floods the cell, activates the proteases, and those proteases relentlessly digest the muscle fiber's own internal proteins.
They eat themselves.
Yes. The cell undergoes necrosis. It literally digests itself from the inside out and dies.
The body obviously recognizes that the muscle tissue is dying, though. Doesn't it try to repair the damage?
The body attempts to heal the microscopic voids left by the dying muscle fibers, but it cannot synthesize new functional muscle tissue easily. Instead, fibroblasts move in and replace the necrotic muscle with dense collagen scar tissue and large deposits of adipose tissue fat.
Just packing the spaces with fat and scar tissue. And this replacement process creates one of the most cruel, deceptive physical signs in all of pediatric medicine. Pseudohypertrophy.
Pseudo meaning false, and hypertrophy meaning overgrowth. Because the dying muscle volume is being heavily infiltrated and packed with bulky fat and fibrous connective tissue, the muscles visually appear to be growing larger.
Right, which is so deceptive. Where is that most evident?
This is profoundly evident in the calf muscles. A young boy with DMD will frequently present with massive, remarkably defined-looking calves. To an untrained eye, they look incredibly strong, almost athletic.
But they aren't strong at all.
No. Palpating those muscles reveals they have a doughy, rubbery texture. It is a false impression of health. The functional muscle tissue is mostly gone.
The sources even point out that if this fat and collagen infiltration heavily targets the tongue, it results in tongue pseudohypertrophy.
Yes, the child develops a massively enlarged tongue that severely impairs speech and swallowing, yet possesses very little actual motor strength.
It's just devastating. And the physical progression of this degeneration follows a highly predictable pattern, doesn't it?
It does. The muscle weakness invariably begins proximally and spreads distally. Proximal muscles are those closest to the core of the body: the pelvic girdle, the hips, the thighs, and the shoulder girdle.
Because they're the biggest load-bearing muscles.
Exactly. These massive muscles bear the brunt of the mechanical stress and therefore tear themselves apart first. The weakness only later moves outward to the distal muscles of the arms, hands, and lower legs.
Let's examine the genetics and the timeline. When did Karens first realize something is catastrophically wrong with their child's motor development?
Well, DMD is an X-linked recessive genetic disorder. The massive gene that encodes for the dystrophin protein is located on the X chromosome. Because females possess two X chromosomes, if one carries the DMD mutation, the other healthy X chromosome typically produces enough dystrophin to compensate.
So the mother is almost always a silent, asymptomatic carrier.
Correct. But boys possess one X chromosome inherited from their mother and one Y chromosome from their father. If a boy inherits the mutated X chromosome, he has no genetic backup system. He will express the disease completely.
But it's crucial to note the epidemiological data in the sources here. Approximately 30% of all DMD cases are the result of spontaneous de novo mutations.
Yes, that's a massive point. This means there is absolutely no history of the disease in the family. The genetic error occurred randomly during the formation of the egg or sperm. This adds a profound layer of shock to the diagnosis for those families.
And the tragedy is further compounded by the initial presentation. When the baby is born, they look and act completely normal.
Right. They do. The dystrophin deficiency takes time to accumulate enough mechanical damage to become visible. The diagnosis is rarely suspected before the age of 3.
What are the very first signs?
The initial clinical signs are often dismissed as subtle developmental delays. The boy might be late to achieve independent walking. When he does begin walking, he frequently exhibits persistent toe walking.
The toe walking. Is that a mechanical consequence of the pseudohypertrophy in the calves?
Exactly. The fibrous scar tissue replacing the calf muscle physically contracts and tightens the Achilles tendon, pulling the heel off the floor.
Wow.
And as the proximal weakness in the pelvic girdle accelerates, the child's body tries to compensate just to remain upright. They develop a pronounced waddling gait.
Just throwing their weight side to side.
Yes, to keep their center of gravity balanced over their rapidly weakening hip flexors and extensors, they adopt a severe lumbar lordosis, an exaggerated arching inward curve of the lower spine, thrusting their abdomen forward. They find it nearly impossible to climb stairs or run.
And this progressive hip and thigh weakness results in a hallmark clinical observation known as Gower's sign.
Yes, Gower's sign.
If you ever see a young child perform this movement, it's a massive, immediate red flag for proximal muscle weakness. Can you break down the exact mechanical sequence of Gower's sign?
Absolutely. Gower's sign is a brilliant, desperate biomechanical workaround invented by the child's central nervous system because their quadriceps and gluteal muscles no longer possess the strength to lift their body weight against gravity.
So they can't just stand up normally.
Right. If you place a child with DMD sitting on the floor and ask them to stand up, they cannot simply push off their feet and rise. First, they must roll their entire body over into a prone position, facing the floor, resting on their hands and knees.
Okay, so they're on all fours.
Yes. Then they push their hips up into the air, keeping their hands planted on the floor, forming a triangle. Then they adopt a hand-to-knee posture. They walk their hands backward across the floor toward their feet, and then they physically grab their own knees.
They're essentially turning their arms into external crutches to support their skeletal frame because the internal muscle supports have failed.
Precisely. From the knees, they transition to a hand-to-thigh posture. They push down violently on their own thighs with their hands, manually forcing their upper torso upright. They literally have to climb up their own legs to achieve a standing position.
Rolling prone, hand to knee, hand to thigh, pushing up to stand.
That laborious, highly deliberate sequence is Gower's sign.
Man, that's heavy. The sources also note a neurological component that is often overlooked in DMD. It states that intelligence is below normal in approximately 30% of DMD patients. Why does a muscle disease affect the brain?
Because the dystrophin protein is not exclusive to skeletal muscle. Isoforms, slightly different versions of the dystrophin protein, are heavily expressed in the synapses of the central nervous system, particularly in the hippocampus and cortex.
So the brain is missing its rebar too, in a way.
Essentially, yes. Its absence disrupts normal neuronal signaling and synaptic plasticity, leading to variable degrees of cognitive impairment and learning disabilities.
Okay, so if a physician observes Gower's sign, pseudohypertrophy, and a waddling gait in a 4-year-old boy, how do they definitively investigate and confirm the diagnosis?
The first, most rapid biochemical investigation is a simple blood test measuring serum creatine kinase, or CK.
Picky kinase.
Yes, CK is an enzyme that normally lives strictly inside intact muscle cells. Because the muscle fibers in DMD are constantly tearing open and undergoing necrosis, they spill their intracellular contents directly into the bloodstream.
So what do the numbers look like?
Well, in a healthy child, serum CK might be around 100 to 200 units. In a child with early-stage DMD, the serum CK levels will be grossly, massively elevated, often reaching 15,000 to 30,000 units.
30,000. It's the biochemical equivalent of finding thousands of bricks and pieces of rebar floating down a river. It proves unequivocally that a massive structure upstream is actively collapsing.
That's a grim but accurate way to picture it. To confirm the diagnosis and rule out other myopathies, a muscle biopsy is performed. A small sample of muscle tissue, usually from the thigh, is examined under a microscope.
And what does it show?
The histology will display precisely the pathological cascade we discussed. Massive variation in fiber size, necrotic fibers actively being digested by macrophages, and extensive proliferation of endomysial connective tissue and fat infiltration.
And the final confirmation.
Finally, molecular DNA analysis from a blood sample is used to identify the exact genetic deletion or mutation on the dystrophin gene. This DNA analysis is also critical for prenatal screening via chorionic villi sampling if a mother is a known carrier and wishes to test family pregnancies.
Okay, the diagnosis is confirmed, the CK is astronomical, the biopsy shows fat replacement. What is the medical management protocol for Duchenne? Is there any way to actually halt the necrosis?
According to the established protocols, there is currently no cure for DMD. The management is entirely palliative, focused intensely on delaying the loss of ambulation and proactively managing the inevitable fatal complications.
And the first step is dealing with the psychological blow.
Yes. The first and arguably most harrowing step in the protocol is the initial counseling with the parents. The physician must sit down and clearly outline the unrelenting, tragic trajectory of the disease, preparing them for the child's eventual confinement to a wheelchair, usually by age 12, and their total physical incapacitation.
The parents must be devastated.
Psychological support, comprehensive social services, and genetic counseling for the mother, who often battles immense psychological guilt as the carrier, must be instituted immediately.
But medically, to slow the progression, the sources again point to the corticosteroid prednisolone, like we saw with MG.
Right. A low daily dose of prednisolone, administered over a period of 6 months to 2 years, has been clinically shown to temporarily improve muscle strength and significantly delay the loss of independent walking.
How does it work for DMD?
It likely works by suppressing the secondary inflammatory response that exacerbates the muscle necrosis. Rigorous daily physiotherapy is also mandatory to stretch the increasingly fibrous muscles, delay the onset of severe, painful joint contractures, and maintain mobility for as long as physically possible.
But the degeneration doesn't stop at the arms and legs. It eventually reaches the involuntary muscles that sustain life, doesn't it?
Sadly, yes. This is the grim reality of the DMD trajectory. As the disease advances into the second decade of life, the diaphragm and the intercostal muscles degenerate and are replaced by fibrous tissue.
So they lose the ability to breathe effectively.
Exactly. The child loses the mechanical bellows required to pull air into the lungs, leading to severe chronic respiratory failure and a high susceptibility to lethal pulmonary infections. Furthermore, cardiac involvement occurs in absolutely all cases of DMD.
The heart is a muscle, too.
Yes, the myocardium, the muscle tissue of the heart, also relies heavily on dystrophin to survive its constant pumping action. The heart muscle slowly undergoes necrosis and fibrosis, leading to a dilated cardiomyopathy.
And the management protocol explicitly lists 2 specific pharmacological interventions for this inevitable cardiac failure: diuretics and digoxin. Let's break down the mechanics of those drugs in a failing heart.
Okay, so when the heart muscle weakens and becomes fibrotic, it cannot pump blood efficiently forward. Fluid begins to back up into the lungs and the peripheral tissues.
That's congestive heart failure.
Right. Diuretics are administered to force the kidneys to excrete large volumes of sodium and water, reducing the total fluid volume in the blood. This drastically lowers the hydrostatic pressure and takes the mechanical workload off the failing myocardium.
And what about digoxin?
Digoxin is a cardiac glycoside. It works by inhibiting the sodium-potassium ATPase pump on the membrane of the heart muscle cells. By inhibiting this pump, sodium builds up inside the cell.
And how does extra sodium help?
Well, it, in turn, slows down a different pump that normally removes calcium from the cell. The end result is a higher concentration of calcium remaining inside the heart muscle cell during each beat, which forces the weakened myocardial fibers to contract with a greater, more forceful mechanical squeeze.
You are artificially whipping a dying heart to keep it pumping.
That's what it amounts to.
But despite the steroids, the physiotherapy, the diuretics, and the digoxin, the prognosis remains universally poor.
It does. Patients rarely survive beyond their second decade of life. The ultimate cause of death is almost invariably cardiorespiratory failure. The respiratory muscles that draw breath and the cardiac muscle that circulates blood simply succumb to the structural collapse.
It's a devastating reality. And it becomes even more stark when we contrast the structural collapse of Duchenne with the neurological decay of spinal muscular atrophy, or SMA. If DMD is a failure of the muscle's internal scaffolding, what is SMA?
If DMD is the collapse of the concrete pillar, SMA is someone systematically taking wire cutters to the high-voltage electrical cables leading to the building. In SMA, The muscle fiber itself is genetically normal. It has perfect dystrophin. The disease pathology is entirely located in the central nervous system. SMA is a relentless degenerative disease that specifically attacks and destroys the anterior horn cells of the spinal cord, as well as the motor nuclei of the cranial nerves arising from the brainstem.
Let's clearly define the anatomy of the anterior horn cells for you listening. The spinal cord is like a massive, bundled fiber optic trunk cable running down your back. Signals originate in the motor cortex of the brain and travel down this trunk.
Correct.
But to make your arm or leg move, the signal has to leave the spinal cord. The anterior horn is the specific exit door at each vertebral level of the spine where the lower motor nerves branch off and head toward the muscles.
That's exactly right. The motor neurons residing in the anterior horn are the final common pathway. SMA causes the progressive apoptosis, or programmed cell death, of these specific lower motor neurons.
So the exit doors are burning down.
Yes. Because the nerve dies at the exit door, the electrical signal from the brain never reaches the neuromuscular junction. The muscle sits there, perfectly healthy, waiting for a command that will never come.
And a muscle that receives no electrical stimulation rapidly undergoes severe denervation atrophy. It just shrinks and wastes away from profound disuse.
Exactly. The sources outline three main types of SMA, but they focus heavily on infantile type A, which carries a specific historical eponym: Verdnig-Hoffmann's disease.
Verdnig-Hoffmann.
Yes, Verdnig-Hoffmann's disease is the most common, the most rapid, and by far the most severe phenotype of SMA. Unlike DMD, which is X-linked and affects almost exclusively boys, SMA is inherited as an autosomal recessive trait.
Meaning both parents have to be carriers.
Exactly. The mutated gene is located on a non-sex chromosome. Both the mother and the father must be silent carriers of one mutated copy, and the child must inherit both mutated copies to express the disease. This means there is a 25% chance of the disease occurring in every single pregnancy for carrier parents.
And the timeline for Verdnig-Hoffmann is radically, heartbreakingly different from DMD. A child with DMD appears developmentally normal at birth and might walk for years. With severe SMA, the nervous system begins dying before the baby is even born.
It does. The clinical manifestations of Verdnig-Hoffmann frequently begin right in utero. As the anterior horn cells undergo apoptosis during fetal development, the fetus loses the ability to move its limbs.
Do the mothers notice?
They do. Mothers will often retrospectively report to obstetricians a highly noticeable, alarming decrease in fetal kicking and movement during the third trimester.
So when the baby is delivered, what does the clinical presentation look like in the neonatal intensive care unit?
In the neonatal period and early infancy, the hallmark sign is profound, extreme hypotonia. The infant is incredibly floppy, often adopting a frog leg posture when placed on their back because they possess zero resting muscle tone to hold their limbs together.
So they can't even hold their own arms up.
Not at all. There is a rapid, severe weakness of the proximal limbs and, terrifyingly, a rapid denervation of the intercostal muscles. They present with a very weak, almost silent cry, a profound inability to swallow leading to pooled secretions, and a massive delay in gross motor development.
So they will never achieve the ability to sit unsupported or roll over.
Unfortunately, no. And when the pediatric neurologist examines the infant, they use a reflex hammer to tap the tendons.
Right, to check the reflexes.
And this reveals a key diagnostic differentiator. A child with Verdnig-Hoffmann will have completely absent deep tendon reflexes, or R-reflexia. If you tap their patellar tendon at the knee, there is absolutely no reflex kick.
Because the loop is broken.
Precisely. A deep tendon reflex relies on a simple, localized nerve loop. The sensory signal goes into the spinal cord, and the lower motor neuron in the anterior horn instantly fires a signal back out to the muscle. Because SMA has systematically destroyed the anterior horn cells, that reflex circuit is physically broken.
That makes total sense. The physical examination sources also list a highly unique, very specific cranial nerve symptom: fibrillation of the tongue. What is the mechanism behind that?
So the cranial nerves emerging from the brainstem control the muscles of the face and throat. The hypoglossal nerve, which controls the tongue, is heavily targeted by SMA.
Okay.
As the motor nuclei feeding the tongue undergo decay, the individual denervated muscle fibers in the tongue begin to fire spontaneously, weakly, and chaotically in a desperate search for a signal.
What does that look like?
Visually, this fibrillation, often called fasciculation, looks exactly like a small bag of worms continuously wriggling and rippling just under the mucosal surface of the tongue. It is a subtle but clinically definitive sign of active lower motor neuron decay.
But here's the aspect of Verdnig-Hoffmann that is almost unbearably cruel. With DMD, the dystrophin deficiency can impact the brain, causing cognitive impairment. With SMA,
With Feardney-Kaufman, mental development is completely 100% normal. The genetic defect in SMA strictly and exclusively targets the lower motor neurons. The sensory nerve pathways carrying touch and pain to the brain, and the complex cortical networks responsible for cognition, personality, and intelligence remain entirely untouched and pristine.
so these children are fully alert, highly perceptive, and perfectly intelligent, cognitively trapped inside a rapidly paralyzing physical shell.
Yes, it's profoundly sad.
How does a physician confirm this diagnosis and differentiate it definitively from a structural muscle disease like Duchenne?
The diagnostic workup involves an electromyogram, or EMG. Small needle electrodes are inserted into the muscle to record the electrical activity.
And what do they see?
Instead of the robust, synchronized electrical wave of a healthy muscle contraction, the EMG and SMA will display a classic denervation fibrillation pattern, the chaotic, high-frequency, weak electrical static of muscle fibers that have lost their nerve supply.
If they perform a muscle biopsy.
The biopsy perfectly differentiates SMA from DMD. Under the microscope, the SMA muscle tissue shows grouped atrophy clusters of muscle fibers that are microscopically tiny and angular because they have shriveled from denervation.
And there's no fat or scar tissue like in DMD.
Crucially, no. You do not see the massive necrotic tearing, the calpain protease destruction, or the extensive proliferation of fat and collagen scar tissue that defines Duchenne. The muscle in SMA is structurally intact. It is simply starving for an electrical command.
Given that we understand exactly which cells are dying, what is the treatment protocol for infantile type A Wernicke-Hoffman?
According to the specific protocols outlined in our sources, there is no definitive medical treatment or cure capable of reversing the anterior horn cell apoptosis. The management is entirely supportive and palliative.
So it's just about making them comfortable.
Yes. Orthopedic interventions and lightweight splinting are used to prevent severe, crippling joint contractures. Respiratory support via suctioning and eventually mechanical ventilation is required. Nasogastric or gastrostomy tubes are surgically placed to ensure nutrition because the child loses the ability to safely swallow.
And the timeline is brutally short.
Very short. The prognosis is incredibly grim because the disease rapidly denervates the intercostal muscles and eventually the phrenic nerve controlling the diaphragm. These infants invariably succumb to overwhelming respiratory failure and aspiration pneumonia, typically before they reach 3 years of age.
If you're a parent or a clinician, reflecting on the difference between these two conditions is just staggering. With Duchenne muscular dystrophy, the child's body appears physically normal at birth, offering years of false hope before a slow, 2-decade-long structural collapse.
Yes.
With severe spinal muscular atrophy, the neurological decay begins in the womb, the timeline is measured in months, and the child's brilliant mind remains fully aware as their motor function vanishes. And yet for both of these profoundly different diseases, one a failure of microscopic cellular rebar, the other a decay of spinal nerve cables, the ultimate lethal threat is identical: respiratory failure.
It is the great tragic equalizer in severe neuromuscular disease. Whether the respiratory muscle tears itself apart from within or the nerve cable commanding it dies, the mechanical bellows that pull oxygen into the lungs and push carbon dioxide out eventually stop moving.
And when respiration drops, the oxygen saturation in the blood plummets. Hypoxia sets in. The brain, which consumes roughly 20% of the body's total oxygen supply, begins to suffocate.
Yes.
And this hypoxic cascade forces us into the next most critical frontier in emergency pediatric medicine: coma.
A coma is the ultimate macroscopic system override. It is strictly clinically defined as a state of deep, unarousable, sustained unconsciousness. The patient is completely unaware of self and environment. They do not have sleep-wake cycles. They cannot respond to any meaningful internal or external stimuli.
Historically, though, the medical community was surprisingly bad at communicating about this profound state of brain failure. They relied on language rather than mathematics.
They did. Before the widespread adoption of standardized scales, neurology relied on a dictionary of highly subjective, descriptive terms. A physician might observe a patient and write in the clinical chart that the child was lethargic, stuporous, obtunded, or in a light coma versus a deep coma.
The flaw there is obvious. It is entirely subjective. I mean, my personal definition of a stuporous child might involve them groaning, while your definition of stuporous might mean they are completely silent but breathing heavily. It is an opinion, not an objective clinical measurement.
Subjectivity is dangerous in an intensive care unit. If a nurse evaluates a child with a head injury at midnight and notes they are lethargic, and the attending neurosurgeon examines the child at 6 a.m. and decides they look stuporous, what actually happened?
Right. Do they get better or worse?
Did the child's brain swelling increase? Did the medication work? You cannot definitively track the trajectory of consciousness based on adjectives. When dealing with brain trauma or swelling, tracking the precise minute-by-minute evolution of the patient's neurological status is the only way to know if your interventions are working or if the brain is actively herniating down the spinal canal. You require rigid, mathematical, reproducible objectivity.
Which brings us directly to the diagnostic coma scales.
Yeah.
The sources detail 3 primary, highly specific scales used in pediatric medicine to replace subjective adjectives with hard, actionable numbers. Let's examine the absolute gold standard first, the Glasgow Coma Scale, or GCS.
The Glasgow Coma Scale was developed in the 1970s and remains the most vital tool for assessing consciousness in older children, specifically validated for ages 4 to 15 years, and adults. Its brilliance lies in its reductionism.
How so?
It breaks the complex phenomenon of consciousness down into 3 distinct, observable, and testable parameters: eye-opening, verbal response, and best motor response.
You test the patient, score each parameter, and add them together. The highest possible score, meaning the child's completely normal, wide awake, looking around and talking perfectly, is a 15.
Correct.
The lowest possible score, representing a deep, unresponsive coma with no brainstem reflexes, is a 3. You cannot score a 0 on the GCS. Even a deceased patient scores a 3. Let's walk through a clinical scenario to demonstrate exactly how the math works, rather than just listing the rubric.
Okay, let's construct a scenario. Imagine a 12-year-old boy arrives in the emergency department after a severe bicycle accident where he struck his head without a helmet. You, the physician, walk into the trauma bay to assess his GCS.
Right. So the first parameter I check is eye-opening. The maximum score is a 4, the minimum is a 1. I walk into the room. If his eyes are already open and tracking me, that is spontaneous eye-opening. He scores a 4, but let's say his eyes are closed. I stand over him and shout his name loudly.
If he opens his eyes to the sound of your voice, he scores a 3. But let's assume he does not respond to speech. His eyes remain shut. You must now apply a standardized, painful stimulus. You press a pen hard into his nail bed, or apply a firm sternal rub to his chest.
I rub his sternum aggressively. He groans and his eyelids flutter open in response to the pain.
That is eye-opening to pain. He scores a 2 for the first parameter. If you applied pain and his eyes remained tightly shut, he would score 1. Next, you assess the verbal response, which carries a maximum score of 5.
I stop rubbing his sternum and ask him, "Can you tell me your name? Or do you know where you are right now?" If he says, "My name is John, I'm in the hospital, my head hurts," he is fully oriented to person, place, and time. He scores a 5.
If he says, "My name is John," but then says, "I'm late for school," he is conversing but confused. That is a 4. If he does not answer your question at all, but just shouts inappropriate random words, apple, dog, stop, that is a 3.
Let's apply this to our 12-year-old in the trauma bay. I ask his name, and he doesn't use words at all. He just emits a deep, guttural moan.
He is making incomprehensible sounds. He scores a 2 for the verbal parameter. If he made no sound at all, it would be a 1. Finally, we assess the most complex and neurologically revealing parameter. Best motor response, scored out of 6.
I look at him and say clearly, "John, hold up 2 fingers." If he holds up 2 fingers, he is obeying commands. He scores a 6.
But our patient is confused and moaning. You will not obey commands. You must apply a painful stimulus again, perhaps pinching the trapezius muscle on his shoulder. If he takes his other hand, reaches across his body, and tries to physically push your hand away from the pinch, he is localizing pain.
Because his brain knows exactly where the pain is.
Yes, his cortex knows exactly where the threat is located in 3D space. That is a highly integrated brain response. He
Wow.
scores a 5.
If I pinch his right shoulder and he just pulls his right shoulder away in a general flinching motion, that is normal withdrawal from pain. He scores a 4. But this is where the motor score gets into highly dangerous, deeply pathological territory, scores of 3 and 2. These represent posturing.
Posturing indicates severe catastrophic damage or pressure on the deep motor tracts of the brain. If you pinch his shoulder and suddenly both of his arms involuntarily flex inward, bending tightly at the elbows and clenching his fists across his chest while his legs extend straight out, that is abnormal flexion or decorticate posturing.
Why do the arms pull inward like that?
It is a mechanical sign of where the brain damage has occurred. Decorticate posturing indicates severe damage to the cerebral hemispheres or the internal capsule, but the red nucleus in the midbrain is still somewhat intact.
And what does the red nucleus do?
The red nucleus drives the rubrospinal tract, which heavily favors flexing the arms. Without the higher brain telling it to stop, the red nucleus takes over and pulls the arms tight across the chest. That scores a 3.
And a score of 2 is even worse.
A score of 2 is abnormal extension or decerebrate posturing. You apply pain, and his arms snap rigidly straight down by his sides, his wrists rotate outward, and his back arches forcefully.
What does that specific outward twisting indicate?
It indicates that the damage or swelling has herniated downwards, crushing the midbrain and the red nucleus. Now, the only motor command center left alive is the vestibular nucleus in the lower brainstem, which drives the vestibulospinal tract.
And that forces extension.
Yes, this tract strongly forces all the limbs to rigidly extend. Decerebrate posturing means the brainstem is actively being crushed. That scores a 2. No motor movement at all, total flaccidity, scores a 1.
Let's calculate the score for our 12-year-old bicycle trauma patient. I applied a sternal rub, and he opened his eyes to pain. That is a 2. I asked his name, and he moaned incomprehensibly. That is a 2. I pinched his shoulder. He pulled away, exhibiting normal withdrawal from pain. That is a 4.
So 2 plus 2 plus 4 equals 8.
The sources state that a GCS score of 8 or less classifies a patient as deeply unconscious.
A score of 8 is the critical clinical threshold. In emergency medicine, there is a famous axiom: GCS less than 8, intubate. At a score of 8, the child's neurological reflexes are so suppressed that they can no longer reliably protect their own airway.
So they might swallow their own tongue.
Their tongue will fall back, or they will aspirate their own saliva. You must immediately intervene with mechanical ventilation.
The Glasgow scale is brilliant for that 12-year-old. But the sources highlight a massive flaw in the GCS when dealing with pediatric medicine. It is only validated down to age 4.
Right, there's a huge developmental issue there.
Yeah. If a 2-year-old toddler is brought into the emergency department after ingesting their parents' medication, the GCS breaks down completely. I cannot ask a 2-year-old what year it is to test if they are oriented to time. They do not know what a year is.
That inherent developmental limitation necessitates the use of the Children's Coma Scale, or CCS. It is a vital modification of the GCS specifically calibrated for infants and toddlers under the age of 4. It maintains the exact same 15-point mathematical rigor, but it heavily alters the parameters to match pre-verbal neurodevelopment.
The major difference resides entirely in that verbal response category. Instead of asking for oriented speech, you rely on behavioral observation.
Exactly. A top verbal score of 5 on the CCS means the toddler smiles, coos, and interacts with their environment and the physician appropriately for their age. A score of 4 means the infant is crying, perhaps because they are in a hospital and scared, but they are consolable. When the mother holds them, they calm down.
Because if they calm down, it proves their brain is processing safety signals.
Precisely. But a score of 3 indicates a deeply irritable pathological state. The child is crying or screaming continuously, and they are utterly inconsolable. The mother rocking them does nothing.
What does that tell the doctor?
This indicates the meninges or the brain tissue itself is physically inflamed or irritated, blocking out comforting sensory input. A score of 2 means they only grunt or moan to pain. A 1 is no response. It elegantly adapts the scale to the reality of a toddler's brain.
The sources detail a third, highly unique scale, the Blantyre Coma Scale, or BCS. The history behind this scale is fascinating. It wasn't developed in a high-tech neuro-ICU.
The Blantyre Coma Scale was originally developed by researchers in Blantyre, Malawi. It was specifically designed to rapidly and accurately assess the level of consciousness in young children suffering from severe cerebral malaria in under-resourced, chaotic field clinic settings.
That's incredible.
It is, and extensive validation studies have proven it is so efficient and effective that it is now utilized globally for children with comas of any etiology.
It is a radically simplified scale. The highest possible score is a 5, and the lowest is a 0. It still utilizes eye, verbal, and motor observations, but it strips away the nuance.
It boils consciousness down to its absolute most primitive binary functions. Eye movement is scored out of 1. Can the child's eyes track a face moving back and forth? Yes scores 1, no scores 0.
So simple. And verbal.
Best verbal is out of 2. Does the child cry appropriately to pain or speak normally? That is a 2. Do they just emit an inappropriate moan? That is a 1. Silence is 0.
And the motor score is out of 2. Can they localize pain by reaching across their body? That is a 2. Do they just withdraw their limb or posture? That scores a 1. No movement is 0.
Exactly.
I have to point out the brilliance of this. If you are a single healthcare worker in a rural clinic dealing with an outbreak of cerebral malaria, and you have 20 sick children in front of you, You do not have the time to debate whether a groan is incomprehensible or inappropriate on a 15-point scale. Distilling consciousness down to a 5-point checklist that can be executed in 10 seconds is an incredible medical innovation.
It prioritizes speed and reproducibility. Any nurse or doctor, regardless of their neurological training, can consistently score a child on the Blantyre scale and immediately know if the malaria is overwhelming the brain.
So you have done the math. You've scored the coma using the Glasgow, the Children's, or the Blantyre scale. You confirm the child is deeply unconscious. The abstract theory ends immediately. You are on a ticking clock. The brain is actively dying. What happens in that very next second? You have to play detective to find the cause, but you can't just start interviewing the parents, can you?
You absolutely cannot. The protocol is rigid and uncompromising. A coma is a profound, life-threatening medical emergency. The very first thing you do, before you ask the parents a single question about the child's medical history, before you draw complex toxicology labs, before you order a CT scan, is institute immediate life-saving resuscitation measures, the ABCs.
Airway, breathing,
Yeah.
circulation. It always comes back to the plumbing and the oxygen.
Because the brain is the most metabolically demanding organ in the body. If it is deprived of oxygen or blood flow for mere minutes, billions of neurons undergo irreversible necrosis. You first establish the airway. If the child's GCS is 8 or below, they cannot protect their airway. You immediately insert an endotracheal tube.
And breathing.
Second, breathing. You connect them to a mechanical ventilator and ensure they are pulling 100% oxygen to saturate whatever blood is reaching the brain.
And circulation. If the child is in hypovolemic shock, if they have lost massive amounts of fluid or blood, their blood pressure crashes. If the blood pressure is too low, the heart cannot physically push the blood uphill against gravity to perfuse the brain.
Right. You must support optimal circulation by pushing massive volumes of IV fluids and utilizing vasopressor drugs to artificially clamp down the blood vessels and spike the blood pressure back up.
Only once the airway is secured, the lungs are expanding, and the blood is forcefully circulating to the brain, do you step back and begin the detective work to find out why the brain shut down.
Exactly. And the sources divide the causes of pediatric coma into two massive, distinct categories. Intracranial, meaning the problem is physically located inside the skull, and extracranial, meaning the problem is somewhere else in the body, but it is chemically poisoning or starving the brain.
Let's dissect the intracranial causes first. These are further divided into structural lesions versus diffuse disease. What defines a structural intracranial cause?
A structural cause means there is a physical, macroscopic mass or lesion actively crushing or tearing the brain tissue. The skull is a rigid, closed bone box with a fixed internal volume. If something new grows or bleeds inside that box, it forcefully displaces the soft brain tissue.
Structural causes include severe physical trauma resulting in a hematoma, right?
Yes, like an epidural hematoma from a skull fracture tearing an artery, or a subdural hemorrhage tearing the bridging veins. It also includes intracranial tumors, massive localized bacterial abscesses, or hydrocephalus.
Hydrocephalus, where the fluid spaces expand.
Right, it's a structural blockage that prevents cerebrospinal fluid from draining, causing the fluid spaces inside the brain to massively expand and crush the cortex against the skull. With structural causes, because a specific anatomical area is being crushed, you are highly likely to see asymmetric focal neurological signs.
For example, the right arm is flaccid, but the left arm is posturing. Or the right pupil is blown wide open and unreactive, while the left pupil is tiny. The damage is localized to one side.
Conversely, a diffuse intracranial cause means the entire volume of the brain tissue is globally inflamed, irritated, or infected. This heavily features severe central nervous system infection.
Meningitis, the inflammation of the protective layers wrapping the brain and spinal cord.
Yes, caused by pyogenic bacteria, tuberculosis, or severe fungal infections. It also includes viral encephalitis, where a virus like herpes simplex directly attacks and destroys the brain parenchyma globally.
And malaria too, right?
Yes, the sources also highlight cerebral malaria, where the malaria parasite causes infected red blood cells to become sticky, clogging millions of microscopic capillaries throughout the entire brain simultaneously, leading to massive, diffuse microscopic strokes and swelling. And finally, post-viral encephalopathies.
What happens in a post-viral encephalopathy?
In cases like post-measles, post-rubella, or HIV encephalopathy, the child actually recovers from the initial viral infection. However, a few weeks later, their immune system, hyperstimulated by the virus, suffers a catastrophic misidentification and initiates a diffuse autoimmune attack against the myelin sheaths of their own brain globally, plunging them into a coma.
Man, That covers the brain being physically crushed or directly attacked. But the extracranial causes are equally complex. These are factors outside the skull that shut the brain down via metabolic starvation or systemic poisoning.
Yeah.
They are split into endogenous and exogenous causes. Endogenous means the body's own organs are failing in generating the poison.
A prime example of an endogenous extracranial cause is severe hypoglycemia. The brain cannot store its own glucose. It relies entirely on a continuous supply from the bloodstream to fuel its massive electrical output. If blood sugar drops dangerously low, the brain literally starves to death and shuts down.
The sources also list diabetic ketoacidosis, or DKA. If a child with undiagnosed type 1 diabetes has no insulin, their cells cannot absorb glucose. The body panics, thinking it is starving, and begins rapidly burning fat for fuel.
And that produces ketones.
Right. This fat breakdown produces massive quantities of acidic ketones which flood the bloodstream, drastically lowering the blood pH. That profound systemic acid buildup chemically suppresses the brain into a coma.
Other endogenous systemic failures include uremia, where the kidneys fail, and toxic urea builds up in the blood to narcotic levels, or hepatic failure, where the liver ceases to filter out neurotoxic ammonia, leading to a hepatic coma. Overwhelming systemic sepsis and massive hypovolemic shock also fall into this category.
Then there is exogenous poisoning. Toxins introduced to the child from the outside environment. The sources provide a massive, fascinating list of toxicological threats that pediatricians must hunt for.
Exogenous causes frequently involve accidental drug ingestion. Toddlers are naturally curious and often ingest poorly secured medications. Barbiturates, salicylates like aspirin, which cause profound metabolic acidosis, or benzodiazepines.
And older kids.
In older children, you must investigate substance abuse involving massive alcohol consumption or narcotic overdoses, which directly suppress the respiratory drive in the brainstem.
The list extends to environmental and chemical toxins, too. Hydrocarbon poisoning from a child accidentally drinking kerosene stored in a water bottle. Organophosphate pesticide exposure, which chemically continuously fires the nervous system until it exhausts itself into a coma. Severe plant poisonings.
Yes. The sources specifically note that ingesting certain wild mushrooms can rapidly induce intense, unremitting seizures, which exhaust the brain's oxygen supply and are quickly followed by a deep coma. And of course, neurotoxic venoms from snake bites or scorpion stings.
But there is one exogenous cause mentioned in the sources that requires specific attention to cultural context. The sources list traditional concoctions. For example, it notes that in some western parts of Nigeria, a traditional remedy involving a mixture containing cow's urine is historically sometimes administered by parents when a child begins to convulse from a high fever.
As medical professionals, it is imperative that we analyze this purely and impartially through a toxicological lens. The parents are utilizing a traditional method in a desperate attempt to halt a terrifying seizure.
Right, they're just trying to help their kid.
Exactly. However, the strict medical reality and the biochemical data provided in the sources explicitly state that the ingestion of this specific cow's urine concoction induces profound, severe hypoglycemia in the child.
Right, so regardless of the cultural intent, the chemical makeup of the liquid drastically tanks the child's blood sugar. The brain, already stressed by the seizure, is suddenly starved of its primary necessary metabolic fuel, which instantly plunges the child from a febrile seizure directly into a deep hypoglycemic coma.
And it highlights exactly why a physician must take a highly specific, culturally aware, and totally non-judgmental, quick history. You have to know exactly what the child ingested to know what biochemical fire you are trying to put out.
The speed of that quick history is the difference between life and death. You must immediately ascertain from the parents, did the child fall off a roof 2 hours ago, or did they drink kerosene, or have they had a fever for 3 days? The urgency is dictated by the fact that treatments for structural versus non-structural causes are radically different and entirely time-dependent.
If the history points to an extracranial metabolic cause, say the parents confirm the child drank the cow's urine concoction, or they are an insulin-dependent diabetic found unresponsive, you do not wait for a neurosurgeon. You push an immediate IV bolus of 10% dextrose.
Because if it's hypoglycemia, that's an instant fix.
Yes. Flooding the starved brain with glucose can wake a deeply comatose child up in a matter of minutes. If the history suggests a severe fever and stiff neck pointing to bacterial meningitis, every single hour of delay increases the mortality rate. You do not wait for the spinal tap results. You administer massive empirical doses of broad-spectrum IV antibiotics instantly.
However, if the quick history and the focal physical signs strongly suggest a structural intracranial cause, the child was struck by a car and now has a unilaterally blown pupil-pushing dextrose, or antibiotics will do absolutely nothing to save them.
Nothing at all.
That child requires a rapid emergency neurosurgical intervention. You have to rush them to the operating room to drill a burr hole through the skull to physically relieve the expanding hematoma before the pressure forces the brainstem down through the base of the skull.
That's the reality of the trauma bay.
Once you have secured the ABCs, taken the rapid history, and ruled out the immediate need for a neurosurgeon's drill, you move to the physical examination.
I love the conceptual analogy for examining a comatose patient. It is exactly like reading the dashboard warning lights of a failing, highly complex engine.
It really is. The patient is completely unconscious. They cannot tell you what hurts or what they swallowed, but their autonomic nervous system, desperately trying to keep the body alive, is screaming the answers at you through their vital signs.
Let's look at the vitals. What are the dashboard lights telling us? Let's start with the pulse and blood pressure.
If you attach the monitors and observe profound bradycardia, an abnormally, dangerously slow heart rate combined with excessively high blood pressure, that is the most critical flashing red light in neurology. And what's that called?
That specific combination is known as Cushing's reflex, or Cushing's triad. It definitively indicates a massive lethal spike in intracranial pressure, or ICP.
Let's explain the physiology behind Cushing's triad. Why does the blood pressure skyrocket while the heart rate plummets?
The skull is a closed box. When the brain swells immensely from trauma or infection, the internal pressure rises so high that it actually exceeds the pressure of the blood trying to pump into the skull. The brain begins to physically squeeze its own artery shut, starving itself of blood.
So it's choking off its own supply.
Yes. The vasomotor center in the brainstem detects the severe ischemia and panics. It triggers a massive sympathetic nervous system surge, violently constricting blood vessels all over the body to force the systemic blood pressure high enough to overcome the pressure inside the skull and push blood back into the brain.
So the skyrocketing blood pressure is a desperate survival mechanism to perfuse a swelling brain. But why the slow heart rate?
When that blood pressure violently spikes, pressure sensors called baroreceptors in the carotid arteries detect the dangerous hypertension. They send a reflex signal through the vagus nerve to the heart, ordering it to slam on the brakes to prevent a stroke.
Wow.
The vagus nerve forces the heart rate to drop precipitously, high blood pressure driven by brain starvation, paired with a slow heart rate driven by vagal reflex. That is Cushing's triad. It means the brain is actively herniating.
The breathing patterns are also incredibly diagnostic. What if the monitors show the comatose child is taking very slow, exceptionally shallow breaths?
Slow, shallow respiratory drive almost exclusively points to a chemical suppression of the brainstem. It strongly indicates exogenous poisoning with sedatives, barbiturates, or narcotic opioids, which bind to receptors in the medulla and physically turn off the urge to breathe.
Conversely, what if the child is exhibiting Kussmaul's breathing? These are exceptionally deep, rapid, sighing breaths. It looks like they've just finished sprinting a marathon, even though they are unconscious.
Kussmaul's respiration is the body's mechanical response to severe metabolic acidosis, most commonly diabetic ketoacidosis. The child's blood is dangerously acidic from ketone buildup.
So it's trying to vent the acid.
Exactly. The peripheral chemoreceptors detect this acid and command the respiratory center in the brainstem to hyperventilate. By taking massive, rapid breaths, the lungs are frantically trying to blow off massive amounts of carbon dioxide. Carbon dioxide acts as an acid in the blood. By exhaling it rapidly, the body is attempting to dynamically raise the blood pH back to a survivable level.
The sources also point to a diagnostic tool that we rarely associate with modern, high-tech medicine: odor. The specific smell of the comatose patient's breath. It is a direct chemical readout of their blood.
In the absence of immediate laboratory results, odor can instantly identify the metabolic etiology of a coma.
If the physician leans in, detects a urinatinous odor.
A breath that smells sharply of urine indicates uremia. The kidneys have completely failed, they cannot excrete waste into the bladder, and massive levels of urea are circulating in the blood and diffusing directly into the lungs to be exhaled.
If the breath has a sweet, heavily fruity odor.
An odor resembling nail polish remover or overly ripe fermenting fruit is the smell of acetone. It is the definitive hallmark of severe ketosis, confirming a diabetic coma.
And a putrid odor, medically termed Phytor hepaticus.
Phytor hepaticus is a sickening, sweet, musty, fecal odor. It indicates catastrophic end-stage liver failure leading to hepatic coma. The dead liver can no longer filter out mercaptan sulfur-containing compounds, so they bypass the liver, enter the lungs, and are exhaled.
And obviously the smell of alcohol or the distinct chemical smell of kerosene on the child's clothes or breath points directly to an exogenous poisoning event.
Right, very straightforward clues.
There are also physical signs completely unique to infants. If a baby under 18 months is in a coma, the protocol demands the physician physically palpate the anterior fontanelle, the soft spot on the top of the skull where the bone plates have not yet fused.
Because an infant's skull is not yet a closed, rigid box, it can visually reflect internal pressure. If the baby has bacterial meningitis creating massive amounts of inflammatory pus or a large intracranial bleed, the volume inside the skull increases.
So it pushes on the soft spot.
Yes, that pressure will push upward against the soft spot. The fontanelle will become visibly bulging, elevated, and feel rigidly tense to the touch, like a fully inflated drum. Furthermore, the protocol dictates meticulously measuring the occipitofrontal circumference, or OFC, to track if rapidly expanding hydrocephalus is physically pushing the skull plates apart.
The physician also checks the ears, mouth, and nose for bleeding or clear fluid, which indicates a basilar skull fracture tearing the meninges. This brings us to the deep neurological exam. You use a pen light to check the pupillary reaction. A blown, fixed pupil means the pressure is crushing the third cranial nerve. You use a fundoscope to look at the retina at the back of the eye for papilledema swelling of the optic disc caused by high pressure. But the sources describe two specific reflex tests that sound incredibly intense. They are vital for checking if the brainstem, the deepest, most primitive, life-sustaining part of the brain, is still electrically alive.
They are intense, yes.
Let's start with the doll's eye reflex, technically called the oculocephalic response.
Before any clinician even attempts to describe or execute this test, there is an absolute, massive, non-negotiable warning in the protocol. You never attempt the doll's eye test if there is even the slightest clinical suspicion of a cervical spine injury or a broken neck from trauma.
Because you could paralyze them.
Violating this rule will sever the spinal cord and permanently paralyze or kill the patient instantly.
Understood. Assuming the child is in a non-traumatic coma, say, from an infection, and the cervical spine is cleared, how does the test physically work?
The physician physically holds the comatose child's eyelids open. Then they take the child's head and rapidly, forcefully rotate it from side to side and then flex it up and down.
Which sounds brutal to do to an unconscious child. What exactly are you looking for in the eyes?
You are testing a highly integrated subconscious reflex arc. If the deep brainstem is intact and functioning, the eyes will smoothly move in the exact opposite direction of the head turn. If you sharply turn the child's head to the right, their eyes will roll completely to the left as if they are stubbornly staying fixed on a point on the ceiling.
Oh, like an old porcelain doll.
Exactly. That is a positive, healthy response. It proves the proprioceptive signals from the neck are communicating flawlessly with the cranial nerves controlling the eyes and the brainstem.
And if the brainstem is dead?
If you turn the head and the eyes simply stay fixed rigidly forward in their sockets, moving with the head as if they are painted onto the face, that is a negative response. It indicates that the reflexive wiring in the midbrain and pons has been physically crushed or destroyed.
The second reflex test is the oculovestibular response, frequently referred to as the ice-water caloric test.
This test is even more physically intense and requires absolute precision. First, the physician must look deep into the ear canal with an otoscope to confirm that the tympanic membrane, the eardrum, is perfectly intact. If there is a perforation or tear in the eardrum, you absolutely cannot perform this test.
Okay, so if the eardrum is intact, then what?
You elevate the comatose patient's head on the bed to exactly 30 degrees above horizontal. Then you take a large syringe and forcefully lavage or flush 20 to 50 milliliters of freezing ice-cold water directly against the eardrum and the ear canal.
What does shooting ice water into the ear do to the brain?
It exploits thermodynamics to test the nervous system. The extreme cold of the water rapidly cools the temporal bone. This cooling creates a massive thermal convection current in the endolymph fluid inside the semicircular canals of the inner ear. The fluid physically sinks as it cools.
And that triggers something.
Yes, this convection current violently stimulates the vestibular nerve, tricking the brain into thinking the head is spinning wildly.
If the brainstem is alive to receive that fake spinning signal, what does it do?
If the brainstem pathways, specifically the medial longitudinal fasciculus connecting the vestibular nuclei to the eye muscles, are intact, you will observe a dramatic, undeniable neurological response. The comatose child's eyes will exhibit a slow, tonic deviation, pulling strictly and forcefully toward the ear that you just filled with ice water.
Wow, it just snaps over to look at the cold.
The brainstem feels the extreme, unnatural cold and reflexively snaps the eyes over to investigate the massive sensory stimulus.
It proves the deep wiring is still transmitting. If you shoot 50 milliliters of ice water against the eardrum and the eyes do not move a single millimeter, the brainstem is profoundly unresponsive, likely brain dead.
Exactly, it's a definitive test.
So you have done the reflex tests. You have ordered the blood cultures, the toxicology screens, the CT scans. You are waiting for the lab to tell you the exact cause. What is the definitive, supportive medical treatment for a coma while you wait for the specific cure to kick in?
Everything circles back to managing the rigid physics of the skull. If the brain is inflamed and swelling, it will inevitably crush itself against the bone. You must aggressively lower the intracranial pressure. The primary pharmacological protocol dictates administering mannitol intravenously.
Mannitol is fascinating. It is a sugar alcohol. How does pushing a sugar into the veins lower pressure in the brain?
It operates entirely on the principle of osmosis. Mannitol is infused into the bloodstream, but it cannot cross the blood-brain barrier. It remains trapped inside the cerebral blood vessels. Because it is a highly concentrated solute, it acts like a massive molecular sponge.
Sucking up the water.
Yes. It creates a powerful osmotic gradient that literally sucks excess water out of the swollen brain tissue, across the blood-brain barrier and into the vascular space. The blood then carries that water to the kidneys, where the mannitol forces it to be excreted as massive volumes of urine. By pulling the water out of the tissue, the physical volume of the brain shrinks, instantly lowering the intracranial pressure.
The protocols also list utilizing dexamethasone.
Dexamethasone is a highly potent, long-acting corticosteroid. It is specifically utilized to reduce inflammation and stabilize the blood-brain barrier, particularly in cases of vasogenic edema caused by tumors or massive abscesses. It tightens up the leaky capillaries in the brain to stop more fluid from escaping into the tissue.
And then there is a mechanical intervention, hyperventilation. I mentioned earlier that Kussmaul breathing is the body hyperventilating itself. But here, the doctor actively hyperventilates the patient using the ventilator. Why?
The brain meticulously regulates its own blood flow, based primarily on the levels of carbon dioxide in the blood. If CO2 levels rise, the cerebral blood vessels dilate to bring in more fresh, oxygenated blood. By artificially hyperventilating the comatose patient with the machine, the physician forces the lungs to blow off huge, abnormal amounts of CO2.
And the brain reacts to that drop in CO2.
Yes, the brain senses this sudden drop in CO2 and violently constricts the cerebral arteries.
Smaller arteries mean there is suddenly significantly less physical volume of blood inside the rigid skull, and less volume means lower pressure.
Exactly. It is a rapid, temporary, life-saving maneuver to drop the pressure while the mannitol takes effect. Concurrently, you must aggressively control any seizure activity with heavy anticonvulsants like phenobarbital. Seizures massively, exponentially increase the brain's metabolic demand for oxygen and generate massive amounts of heat and pressure, which a comatose brain cannot survive.
And ultimately, you treat the underlying cause. You push the dextrose for the hypoglycemia, you pump in the broad-spectrum antibiotics for the meningitis, you rush them to the operating room to evacuate the hematoma.
You buy time until a specific fix can be applied.
We have covered an immense, staggering amount of clinical ground today. We started at the microscopic level, decoding the invisible autoimmune blockade of acetylcholine receptors in the busy parking lot of myasthenia gravis. We zoomed out to witness the catastrophic structural collapse of the dystrophin rebar, tearing the muscle fibers apart in Duchenne muscular dystrophy.
A lot of ground indeed.
We tracked the tragic silent decay of the anterior horn nerve cables in the spinal cord in spinal muscular atrophy. And we journeyed all the way to the macroscopic, terrifying medical emergency of a pediatric coma, exploring the vital, elegant mathematics of the Glasgow and Blantyre diagnostic scales utilized to measure it.
Grasping these intricate pathophysiological details, understanding the exact cellular mechanisms of highly specific drugs like neostigmine and bigoxin, and memorizing these rigid clinical scales is not just an exercise for passing a medical board exam. It is about recognizing the profound, terrifying fragility and simultaneously the resilient and mechanical wonder of the human nervous system.
And it leaves us with something really provocative to think about. Consider the historical evolution of those Toma scales we discussed. We moved from vague, highly subjective adjectives like lethargic and stuporous to the rigid, life-saving objective math of the Glasgow and Blantyre rubrics. It fundamentally changed how we track consciousness and save lives in the trauma bay.
It forces a fascinating question. As our understanding of brain activity deepens exponentially with incredible emerging technology like advanced continuous EEG monitoring and functional MRI, what will the coma scale of the future look like?
That's a huge question.
Will we soon measure a child's consciousness, not by observing whether they can physically withdraw their arm from a painful pinch, but by directly, algorithmically reading the electrical whispers of a highly active mind trapped in the dark?
That is an incredible thought. Maybe one day, that broken X-ray machine we talked about at the very beginning will be replaced by a technology that can finally see clearly directly into the murky waters of consciousness itself. Thank you for joining us on this deep dive. Stay curious, keep looking for the mechanical connections, and always keep questioning the why behind the clinical facts. We'll see you next time.